Hello. CR, am I audible? Hello.
Yes,
Yes,
sir.
sir.
Okay, okay. So today we will start with pharyngeal and esophageal diverticulum. And next to that, we will take a topic on carcinoma esophagus. So starting with pharyngeal and esophageal diverticulum. So a diverticulum is a abdominal sac or pouch which is formed through a weakest point from the alimentary tract. So it can be there right from the esophagus to the rectum. It's a record. So these are the two types of diverticulum which we generally encounter. Sound I say. So one is traction diverticulum and another one is the pulsans diverticulum. So this traction diverticulum, it occurs mainly secondary to some granulomatous infection. And here this is the pulsans diverticulum which occurs as a result of some weakness in the alimentary tract because of increase in the intraluminal pressure. So most of the esophageal diverticulum are pulsans diverticula. And as I have said, it develops at a site of weakness, which occurs as a result of a chronic pressure against an obstruction. So symptoms are mostly caused by the underlying disorder, unless the diverticulum is particularly large. So these diverticulum may become larger with time. So regarding tractions diverticula, they are less common as compared to pulsans diverticula. So it mostly occurs as a consequence of chronic granulomatous disease affecting the tracheobronchial lymph nodes due to tuberculosis or atypical mycobacteria or histoplasmosis. So fibrosis occurs on healing. So this exerts traction on the esophageal wall, and thereby it produces a focal outpouching, which is usually small and is conical in shape. And it is sometimes associated with broncholithiasis. And we may encounter additional complications like aerodigestive fistulation and bleeding. So aerodigestive fistulation means fistula formation or abdominal tract between the trachea and the esophagus. So we have pharyngeal pouch, that is also known as Janker's diverticulum. So it is not really an esophageal diverticulum. So it is situated above the clicopharyngeal sphincter. So ideally, to say it as a esophageal pouch or diverticula, it has to be below the level of the clicopharyngeal sphincter. So it protrudes posteriorly. This Janker's diverticulum, here we can see this is a posterior protrusion of a sac, or this is the diverticula. So this is Janker's diverticula. So it occurs through a weakness that is known as triangle of Killian, so which is between the oblique and the horizontal fibers of the inferior pharyngeal constrictors. So this is that triangle, Killian's triangle. So this is the horizontal fiber, and these are the oblique fibers. So through this triangle, Janker's diverticulum develops. So this is again another picture. You can see this is the oblique fibers, and these are the horizontal. And barium picture, it gives a view of a pouch. You can see here, which is posteriorly situated in relation to esophagus. So the exact mechanism that leads to its formation is not known, but it involves loss of coordination between the pharyngeal contraction and opening of the upper esophageal sphincter. So this is the endoscopic view. Okay, so this is the esophagus, lumen of the esophagus, and this is the pouch where we can see fluid is getting pent up, and this is the septum. So when the diverticulum is small, symptoms largely reflects this incoordination with predominantly pharyngeal dysphagia. So sense of stickiness will be there in the pharyngeal region, but as the pouch enlarges, so the food matters, they get filled up in the pouch, and gradually the fundus of the pouch, it descends. So it may descend up to the mediastinum. So this leads to halitosis, that is foul breath, and esophageal dysphagia. So gradually from pharyngeal dysphagia, it will turn up to esophageal dysphagia as the pouch enlarges. So patient will feel something obstructing in the thorax later on as the pouch enlarges in the midline. So that is the symptoms. So far as treatment is concerned, treatment can be undertaken endoscopically with a linear cutting stapler by dividing the septum between the diverticulum and the upper esophagus and producing a diverticulo-esophagostomy. So here we can see the stapler is being applied. So one blade of the stapler is in the pouch and another in the upper esophagus. So they are approximated and it is fired. And on firing, we can see this, there will be stapling, and on releasing the fire, then it will cut. So here in this picture, we can see there is division of the septum. So this is the surgery which we can do endoscopically. So a track is created in between the sac and the esophagus. Similarly, it can be done by open approach. So we dissect the diverticulum, and diverticulum is isolated. So, and we excise it and we repair the base of the diverticulum, and plus minus we can go for myotomy of the precopharyngeus muscle. So here we can see this diverticulum is separated, myotomy is being performed, and it will be divided, and it will be repaired. So the procedure will be pouch excision, pouch suspension, or we can say diverticulopexy without myotomy. So this myotomy is done in order to relieve functional obstruction. So it's better to do myotomy. So on releasing the muscle fiber, we can see the mucosa, it's pouting out through the area of the esophagus. So all techniques have good results. So next we have the Killian-Jamieson's diverticulum. So it is an outpouching from the lateral wall of the proximal cervical esophagus. So it is in the upper esophagus, and the pouching is it arises from the lateral wall of the esophagus, and is less commonly encountered compared to Zenker's diverticulum. So it arises from in between the fibers of cricopharyngeus superiorly and longitudinal muscle of the esophagus inferiorly. So here we can see this is the cricopharyngeus muscle, and these are the horizontal, this longitudinal, sorry, muscle. So here we can see laterally, we can see a bulge. So this is the diverticula. So lateral diverticula is Killian's Jamieson diverticulum. But if we find here bulging is coming out, then that is Zenker's diverticulum. So here also similarly we isolate it. This is the esophagus and this is the diverticulum. So we'll cut the base here and we'll do the diverticulopexy, and thereby we'll finish the operative procedure. So next, if you go down, is the mid-esophageal diverticula. So here the diverticulas are small and pulsans diverticula, and the underlying motility disorders does not usually require treatment here. And some pulsans diverticula may fistulate into the trachea, but this is more common with the tractions diverticula in granulomatous disease. So usually no treatment is required in this case, and these are very small pulsans diverticula. So next, if you go down, further down, we'll get a epiphrenic diverticula. So this diverticula will be above the diaphragm. So these are also pulsans diverticula, which is situated in the lower esophagus above the diaphragm. And this may attain large size, but surprisingly, it causes fewer symptoms. So they again probably reflect some loss of coordination between the incoming pressure wave and appropriate relaxation of the lower esophageal sphincter. So this is the barium X-ray, which is showing a large diverticula in the lower esophagus. So large diverticula, so we have to dissect through the hiatus. So here we can see this is the hiatus. So the diverticula is somewhere inside the thorax. So it is been dissected out, myotomy is performed, and now from the thorax it has come out to the abdominal cavity. So here we can see huge diverticula, and here the crural repair can be seen. So we'll excise this one, and simultaneously the repair is done. So here also excision of the diverticula is the treatment, followed by myotomy. So in order to relieve functional obstruction. So these are the different types. So here it is arising posteriorly, that is the Janker's diverticulum. So posteriorly and above the cricopharyngeal sphincter. Okay. So this is Janker's diverticulum. And here we can see this is the diaphragm. It is above the diaphragm, that is, it is arising from the lower esophagus. So this is your epiphrenic diverticulum. And here we can see the mid thoracic diverticulum. So here, because you can see the carina, trachea, and so on. So this is the diverticulum, which is mostly traction diverticulum, which occurs secondary to some chronic granulomatous pathology. So this is about the diverticulums. So next big topic is carcinoma of the esophagus. So carcinoma of the esophagus is the sixth most common cancer in the world, and it occurs in the mid and late adulthood and has a poor survival rate. So it causes great misery to the patient because the patient here are in a position that uh, they are unable to swallow even liquid food. So only 5 to 10% of those diagnosed will survive for 5 years. So that is the survival rate. So chances of that is more because they mostly present very late. So these are the etiological factors. So among that we have alcohol and tobacco, achalasia cardia, esophageal webs, Barrett's esophagus, Plummer-Vinson syndrome, corrosive strictures, tylosis, nitrosamine, and so on. So these are the etiological factors which are responsible for causation of carcinoma esophagus. So achalasia cardia. So here we can see that it is due to incomplete or delayed relaxation of the lower esophageal sphincter, and there is absence of peristalsis in the body of the esophagus. So this we have already discussed in the previous lecture. So here typically what we are going to get is the bird beak appearance or rat tail appearance. So here there is absent peristalsis in the body of the esophagus, and there is delayed relaxation of the lower esophageal sphincter. So as a result of this, food matters they get accumulated there for long, and as a result of that, there will be esophagitis. So this esophagitis, it leads to carcinoma of esophagus if it is not treated. This is the esophageal web. So here we can see the web structure. This is the web. This is the web. So this is also responsible for carcinoma esophagus. So next we have the Barrett's esophagus. So here we know that the normal epithelium is replaced by the diseased epithelium. So the squamous epithelium of the lower end of the esophagus is replaced by the diseased columnar epithelium. So next we have the Plummer-Vinson syndrome, which is a rare disease characterized by difficulty in swallowing, iron deficiency anemia, glossitis, chelosis, and esophageal web. So this is also one of the factor which causes squamous cell carcinoma in not only in the esophagus but in the oral cavity as well as the hypopharynx. So the treatment here is iron supplementation and mechanical widening of the esophagus. Next, we have the corrosive injury. We have already discussed in the previous lectures. And here the malignant transformation is reported in around 5% of the cases. So this is also one of the factor responsible. Next is the tylosis. So it is a genetic disorder characterized by thickening of palm and sole and white patches in the mouth. So this is a predisposing condition to squamous carcinoma, cell carcinoma of the esophagus. And most important is the exposure to nitrosamine. So through barbecued meats or pickled vegetables. So this is also responsible for creation. So coming to the pathology. So pathology, the most common types are the squamous cell carcinoma and adenocarcinoma. So squamous cell carcinoma generally affect the upper two-thirds of the esophagus, and the adenocarcinoma affect lower one-third. And worldwide, the squamous cell carcinoma is most common, but the adenocarcinoma predominates in the West, and it is increasing in incidence nowadays because of westernization of diet. So coming to the macroscopic variety, so it has annular stenosing lesion, or we may encounter epitheliomatous ulcer, or it can be fungating cauliflower with fibril mass, or polypoidal variety, or varicoid, that is the diffuse submucosal type. So regarding the site of involvement, so most common is the middle third of the esophagus is involved. The incidence is around 50%. And next to that is the lower third, that is 33%. And upper third is around 17%. So these are the site of involvement. So coming to the spread, so spread can be direct spread, it can be lymphatic spread, it can be hematogenous, and it can be transperitoneal. So direct spread is the main mode of spread, and it is mainly seen because of lack of serosal layer. So here the spread occurs both transverse or longitudinal direction, and it may erode the muscular wall to invade the other important structure of the neck, posterior mediastinal, left main bronchus and trachea. So the longitudinal spread mainly spread via the submucosal lymphatic channel of the esophagus. So next is the lymphatic spread. So lymphatic spread, it occurs via permeation and embolization. So submucosal lymphatic permeation may lead to satellite nodule formation away from the tumor. So always there is nodule formation away from the tumor. So any regional lymph node may get involved, right from the superior mediastinum to celiac and the lesser curvature of the stomach. So anything can be involved. So here the nodule formation is away from the tumor. And next is the embolization. So embolic spread occurs like if the growth is in the cervical esophagus, then the spread will be in the lymph nodes of supraclavicular triangle. And if the growth is in the thoracic esophagus, the lymph node of the paraesophageal or tracheobronchial lymph nodes, then it may extend downward to the subdiaphragmatic lymph nodes. So these lymph nodes can be involved. And in case of involvement of the abdominal esophagus, so lymph nodes around the lesser curvature, then around the celiac axis may be involved. So, APK upgrade. Okay. So next is the hematogenous spread. So it's spread via blood route. So variety of different organs are involved, say including liver, lung, brain, and bone. So next is the transperitoneal. So the tumor arising from the intra-abdominal portion of the esophagus may also disseminate transperitoneally. So these are the common mode of spread. Next, we have the clinical features. So clinical features can be dysphagia, this can be regurgitation, there can be vomiting, there can be odynophagia and weight loss. So these are the usual presentation. But as case advances, so with advanced malignancy, patient may complain of hoarseness of voice, which is due to recurrent laryngeal nerve palsy, or there can be liver secondary or ascites, or if the spine is involved, so there can be chronic spinal pain. If the chest is involved, there can be bronchopneumonia, or if the diaphragm is involved because of the phrenic nerve irritation or involvement, the patient may have hiccups or diaphragmatic paralysis. And besides that, we may get palpable lymph nodes in the neck. So these are the presentations which we may find in advanced cases. So coming to the investigation part, so we have already discussed like investigation like barium swallow, esophagoscopy, biopsy, chest X-ray, bronchoscopy, esophageal endosonography, CT scan, or ultrasound abdomen plays an important role. So these are the basket of investigation which we can give to the patient. So barium swallow, as we all know, so it helps in establishing the length of the tumor in case when the endoscope cannot be negotiated. And it is helpful to see any distortion of the axis of the esophagus. So here we find two signs. Number one is the irregular filling defect and shouldering sign. So here we can say these are the irregular filling defect. These are the irregular filling defect. This is the shouldering sign. So this is the sign which we are going to get in barium X-ray. So this is also, these are the filling defect. Here, this is a filling defect. Thereby, we can see the narrow lumen of the esophagus. So next is the endoscopy. So it helps in direct visualization of the growth, and it allows biopsy. So biopsy is should be done for confirmation and to know the histological type. So the lesion, the extent, and the type of the growth can be assessed with the help of endoscopy. Next, chest X-ray is important pre-operatively to look for aspiration pneumonia, or to see for vocal cord palsy, or to identify any fistula formation. So bronchoscopy is the next tool of investigation, and it is mainly helpful in cases of middle and the upper third esophageal cancer. It is not helpful in the lower third of the esophageal involvement. So when there is a middle or the upper third esophageal cancer, then we should advise bronchoscopy in order to see any involvement of the bronchus with the esophagus. So next is the esophageal endosonography. So this we can do to see the layers of the esophagus or the node or cardia or the left lobe of the liver involvement. So here nodes smaller than 5 millimeter can be visualized, which is often missed by the CT scan. So besides that, we can also do FNAC through the endoluminal sonography. So next is the CT scan. So CT scan has a 95% accuracy rate, and two, we can see the local extension, nodal status, and the extraesophageal invasion. So if a CT scan is done, sonography is not required. Sonography may be required as a follow-up after surgery to rule out secondaries. Next, we have the diagnostic laparoscopy. So it is done to prevent unnecessary laparotomy in case of carcinoma esophagus. So first, we have to see whether the case is resectable or not. So in order to see whether it is resectable or not, we do diagnostic laparoscopy. And once we introduce the laparoscope into the peritoneal cavity, and once it is clear that it is operable, then we proceed for this bigger intervention. And moreover, with the diagnostic laparoscopy, we can see the peritoneal seedling, which is not detected in CT scan. So PET scan is another investigation, that is the positron emission tomography, which uses FDG, that is fluorodeoxyglucose. So this FDG, it enters the highly active cells, and the phosphorylation occurs, and it turns the FDG into FDG6 phosphatase. So it stays in the cells as an end product, and it gets polarized there. So PET scan is basically done after surgery to see or to look for any residual tumor, or following chemotherapy to see the response of the treatment. So recent advances in the early carcinoma esophagus. So this is one investigation which we can do. It is the endoscopic esophageal staining with the radio level iodine. So radio level iodine, so this is the normal view. So here it is stained with the radio level iodine. So normal esophagus, the mucosa gets stained and it appears brown. And the affected mucosa doesn't take up the stain, and it remains as a pale. It remains pale in color. So here we can see this is the pale in color, this is brown. So this is the involved area. These are the involved area. These are the involved areas, and these are the normal area. So here also by naked eyes we can see some defect here. So which is here, it is not taking up the iodine. So these are the defective areas. So this is one we can do for detection. And if we find that there is a small lesion like 1.5 centimeter or 2.5 centimeter growth, then we can go for endoscopic mucosal resection. So these are the small growth. If we find growth like that, so we can endoscopically we can resect. So what we do is we inject saline in the base, and it is bulged out, and after that we use snare or cutting device to remove this uh, small growth. So this is applicable for smaller lesion, uh, 1.5 to 2 centimeter in size. So coming to the treatment part, so the algorithm which we may follow is this one. So the first of all, patient must be fit for surgery, and he should not have any type of spread like hematogenous spread, direct spread, or peritoneal spread, or lymphatic spread. So if patient is fit and has no spread, then surgery alone is sufficient. Otherwise, if a patient is having hematogenous spread or direct spread or peritoneal spread, we cannot go for surgery. So the better management will be palliation. And if a patient is fit and there is only lymph node metastasis, then we can go for multimodal therapy, that is curative resection and chemotherapy and radiotherapy. So this algorithm is shows if the patient is fit, yes, then we have to see whether there is any hematogenous spread or any direct spread, peritoneal spread, or lymphatic metastasis. If there is none of these, then we can go for surgery. But if patient is not fit, directly palliation. If a patient is fit and there is hematogenous spread, there is a role of palliation, no surgery. Similarly, direct spread, if there is direct spread, palliation. If there is peritoneal spread, there is palliation. But if there is lymphatic metastasis, then we can take surgery along with chemotherapy and radiotherapy as a treatment option. So this algorithm we have to follow. So this is the TNM classification. So this is the TNM classification, as I have said. So it is the T. So Tx is the tumor cannot be assessed. T0 is no tumor. Ti is high grade dysplasia. And when we say T1, it is the tumor invading the lamina propria, mucosa, and submucosa. And when we say T2, it is when tumor invades into muscularis propria. And as there is no serosa here, directly from muscularis propria, it will invade the paraesophageal tissue. So T3 when the tumor invades the paraesophageal tissue. And T4 is when tumor invades the adjacent structure. So this is the tumor factor. Next we have the nodal spread, N. So N-X is regional lymph nodes cannot be assessed. N0 when no regional lymph node spread is seen, and when is the regional lymph node spread is seen. And regarding the distant metastasis, that is the M. So it can be MX where spread cannot be assessed. M0 is no distant metastasis, and M1 is when there is metastasis, distant metastasis. So M1 is further divided into M1A and M1B. So M1A is upper esophageal tumor, it spreads directly to the cervical node, or middle tumor, it spread to the mediastinal node directly, and the lower tumor, it spreads to the celiac node. So there is a direct spread to the respective nodes. But when we say M1B, the upper tumor, it can spread either to the mediastinum or the celiac node. It will not spread to the cervical node. So similarly, middle tumor, it spread to cervical and celiac, or the lower tumor, it spread to cervical and mediastinal node. So then only we can say it is an M1B type of spread. So this is about the TNM. So these are the stages. So stage 0 will be tumor in situ or N0 M0. Stage 1 is T1 N0 M0, or stage 2B, that is T2 N0 M0 or T3 N0 M0. Stage 2B is T1 N1 M0 and T2 N1 M0. Stage 3 is T3 N1 M0 or T4 any N M0. And similarly, stage 4A is any T, any N, and M1A. And stage 4B is this is any T, any N, and M1B. So these are the staging as per TNM classification. So generally, at the time of diagnosis, around 2/3 of the patient they come in very poor shape. So many patients have nutritional deficiencies, and prior to surgery, we have to correct this deficiency to near normal state. And if the growth is resectable one, then we should not do feeding gastrostomy. If we see that it is an unresectable growth, then we have to go for feeding gastrostomy. Why? Because if we do feeding gastrostomy in case of resectable growth, then we are damaging the stomach. So these stomach will be used as a conduit in operation. So we should not do. So Once again, if the growth is resectable, we should not do feeding gastrostomy. And if it is unresectable growth, then we have to do for feeding gastrostomy. And 20% of the cases, they present early and they become curable. So early cases means growth with absent nodular spread, only T1 and T2, no node involvement. So here in that case, we go for radical esophagectomy. That is the treatment of choice. And if nodes are present, then multimodal approach should be used, which includes curative resection, radiotherapy, and chemotherapy, which we have already discussed. And there is some role of neoadjuvant therapy before surgery, that is application of chemotherapy before surgery is the neoadjuvant therapy in order to reduce the size of the tumor. And next is the chemoradiation. This can also help, especially in the case of squamous cell carcinoma. So in rest of the 80% of the cases, so palliative therapy is the main course of treatment. So only 20% cases can be cured. In rest, 80% of the cases will need palliative therapy. So we have a small area that is the post-cricoid carcinoma. So here we can get also carcinoma. But here treatment is not preferred because it is very difficult to obtain an adequate tumor-free margin. So we cannot go for pharyngeal with tracheostomy, as it is associated with a high complication rate. So that is why in such case, radiotherapy is the treatment of choice. So we should not go for surgery, but we should try with radiotherapy in such case. So carcinoma of the upper third of the esophagus. So when upper third is involved, and then we have to go for a surgery which is known as McQueen's three-stage esophagectomy. So if it is operable one, then we go for McQueen's three-stage esophagectomy. Otherwise, if it is an inoperable case, then simply we have to go for radiotherapy. So here in McQueen's three-stage operation, so what we have to do is we have to do laparoscopy first. We open the abdominal cavity and we look for the signs of inoperability. And if we find that it is operable one, then we mobilize through the laparotomy wound. We mobilize the stomach through the laparotomy wound. And then we open the thorax. So right lateral thoracotomy is done. So through fifth intercostal space in the right side, we open the thorax and we mobilize the esophagus. And through the left side of the neck, the esophagus is, along with the growth, is removed. So these are the steps of McQueen's three-stage esophagectomy. So after removal of the esophagus, it is replaced by a conduit, so which is usually formed with the help of stomach, or if stomach is not available, we can use colon or jejunum. So these are known as esophageal substitute or esophageal conduit. So anastomosis is done between the pharynx and the stomach, which is a neoesophagus in the neck. So anastomosis is done in the cervical region. So next we have the carcinoma of the middle third of the esophagus. So if surgery is undertaken, the operation is partial esophagectomy with esophagogastric anastomosis at the level above the aortic arch. So the operation is known as Iver-Luis operation. And after we do Iver-Luis operation, feeding jejunostomy must be performed. So carcinoma for the lower third of the esophagus, or when the cardia is involved, in that case we go for esophagogastrectomy through the left thoracoabdominal incision, and the gastric tube is made and anastomosis is done. Or These are the options. If stomach is not available, then we can use the jejunal loop for anastomosis. So we have the jejunal Roux-en-Y anastomosis or jejunal loop or Brown's anastomosis. So this is the Roux-en-Y. So here, this is the distal. This is the esophagus. So the esophagus is removed. Stomach is removed. So here, this is the duodenum. Duodenum is repaired, and ultimately the jejunum is transected here, and the distal jejunum is advanced into the thorax, and the esophago-jejunal anastomosis is done here, and side by side jejunal anastomosis is done here. So this is Roux-en-Y anastomosis. Then here we use a loop with interposed segment. So one segment of jejunum is sutured here. Anastomosis is done in the esophagus as well as with the duodenum, and other is jejunal anastomosis is done. So this is the loop. Here again, this is the Brown's anastomosis. So here a loop of jejunum is anastomosed with the distal esophagus, and here we do jejunal anastomosis. These are the options which we have. And next to that, we have the transhiatal total esophagectomy. So here, without opening the thorax, we remove the entire esophagus through the hiatus. So it is a blind procedure, and the anastomosis here is done in the neck. So this is known as Oringer's approach. So these steps we have already know the steps. So this is the laparotomy is performed. This is the stomach. Stomach is mobilized. So here further stomach is mobilized. You see this is the posterior surface of the stomach. This is the stapler. It's been used to transect the attachment of the stomach. So here we can see the whole posterior stomach nicely. So adequate mobilization of the stomach is performed. So here we can see the myotomy is being done. So this is the pyloric side. So it's the myotomy is done. And this is the thoracic view. So in the thorax, we separate the esophagus. So this is the esophagus in the thorax. And this is further mobilization. This is the esophagus. Further mobilization is being performed. See, this is the thorax. So inside the thoracic cavity, further mobilization of the esophagus is done. So further, and ultimately this is the neck incision. So left side of the neck is selected. So we dissect the esophagus ultimately. So these are the strap muscle or the omohyoid muscles being transected, and ultimately this is the esophagus. This is the esophagus which is separated. This is the recurrent laryngeal nerve we can see. Now this esophagus here will transect it, and ultimately the new esophagus which is made, it is pulled up through the thoracic cavity, and it will be anastomosed here. So this is the esophagus which we can see here. This will be transected. So the stapler is applied for transection purpose. And this is the neo esophagus which is made out of the stomach. So this is the stomach, and this is the marking done. And here this will be removed, and ultimately the stomach will be turned into a tube. So you see this is in the process. So here staplers are used and it is being fired, and ultimately the stomach is converted into a tube. So this is the tube which is made from the stomach, and this will be passed through the thorax, and it will be brought from the cervical incision, and the anastomosis will be done here with the esophagus, cervical esophagus, and this neo-esophagus which is created with the help of stomach. So this is the neo-esophagus which is being pulled out through the peritoneal cavity, via thorax, it will go to the cervical region. So here it is in the cervical region. So again, it's the process of anastomosis. It's being done here. We can see anastomosis has been done. Yeah, so see here we have seen the anastomosis. This is done. And after this anastomosis is done, we have to go for a feeding jejunostomy. So feeding jejunostomy in order to feed the patient artificially. So this is the colon. This is the colon. Colon is lifted up. So when we lift the colon, so here we get is the DJ flexure, which is the fixed part. So this is the from here the jejunum will start. So we isolate the jejunum. We identify the jejunum first through the DJ flexure, and then we isolate a segment through which we have to perform a feeding jejunostomy. So we make a hole here in the jejunum. We introduce a tube inside. It is repaired, and thereby feeding jejunostomy is performed. So this will help in artificial feeding of the patient till patient recovers from the operation. So for squamous cell carcinoma, as spread is upward, so thoracoscopic, laparoscopic, radical esophagectomy or open radical esophagectomy with 3-field clearance lymphadenectomy is usually prescribed. So 3-field, that is 3 fields should be cleared: celiac, thoracic, and the mediastinal, this one, cervical nodes. And here in adenocarcinoma, as the spread is downward, 2-field clearance is advocated, that is celiac and thoracic node clearance. So palliative therapy should be simple and effective. And so surgical resection and external beam radiotherapy may be used as a palliation, but is usually not suitable as expected survival is very short. So as it is a main problem, so better to go for a simple palliative therapies. No surgery is advised. So these are the palliations which we can try, like expanding metal stent, endoscopic anti-arc laser treatment, or bipolar dithermy, or argon beam coagulation, or alcohol injection. So these are the group of palliation available. So what it will do, it will temporarily open the lumen of the diseased esophagus. And after some time, again, the lumen may get blocked because of the growth. So these are the options which we have nowadays. So brachytherapy is also one of the options. So directly the tumor gets the radiation. So chemotherapy is also one of the options. So the agents which are used is cisplatin, methotrexate, 5-FU, paclitaxel, etoposide, and bleomycin. So platinum-based chemotherapy are beneficial, especially in cases of advanced adenocarcinoma. So coming to the terminal complications of carcinoma esophagus. So when unresectable, so that is imminent. So that can occur in these following ways. So patient may become more cachexic and dehydration, and ultimately there will be death. Or there can be pneumonia following perforation into the bronchial tree, or mediastinitis from perforation into the posterior mediastinum, or rarely there can be erosion of the aorta leading to massive bleeding and death. So these are the terminal complications which we may encounter if it is unresected. So with this, we end today's lecture. Thank you.